It's time. It's time for you to live better.
It's time for you to feel healthier.
It's time for you to live longer.
It's time for you to enjoy your journey.
It's time for you to understand your body and your mind. Thank you so much for joining us on It's Time today. We are your hosts. I'm Linsly Donnelly, your citizen scientist and your longevity expert for midlife women.
And I'm Dr. Jayne Wagner, physician and holistic performance expert. Welcome to It's Time, powered by Prosper. Just a quick reminder, the information discussed in this podcast is for informational and educational purposes only. We are not offering medical advice, nor are we entering into any type of physician or clinician relationship with listeners. Always consult your healthcare provider before beginning any new fitness, nutrition, or lifestyle changes to ensure they're right for you. Your health and safety is our priority, and let's keep it that way. Thank you.
All right. Welcome, everybody. We're so excited to have you back. Today, we have with us Dr. Jayne Morgan.
Hello. Hello, everyone. Thank you for having me today.
Oh, thanks for joining us. Jayne, will you give us a little bit of your background? Because we're going to talk about a topic that is so important for women. It's still the number one killer of women, even though we tend to deprioritize it in our lives, which is heart disease.
Yes. Yeah. What about that? Yeah, I am a cardiologist. I spent a good part of my career, really in research, and then transitioning over into a lot of communications and education. I have a big background in the biotech industry, startup companies. In fact, I am the vice president of medical affairs for a digital heart health company that is focusing on women. It's called Hello Heart. And we provide a remote blood pressure monitor such that you can monitor your blood pressure all the time, because blood pressure does what? Increases your risk of heart disease, increases your risk of brain disease, increases your risk of kidney disease, goes up during menopause, is a risk factor for pregnancy. So we are really expanding into the women's health space. And obviously that's my sweet spot, that and minority communities, especially with regard to clinical trials. I try to talk a lot about the importance of heart disease in women. I know breast cancer gets a lot of press, and people get up in arms about breast cancer, and rightly so. It certainly is a health threat, but we certainly made great strides there recently as well. But I do want to say that heart disease kills more women than not only breast cancer, but all of the cancers combined, plus breast cancer. Heart disease still beats them. So we've got to begin to get that message forward. This is not a disease of men. This is a disease of women. And that's part of the problem, that the health system focuses on men. And then we get the wrong messages and sort of, run down these rabbit holes. So I appreciate you having me here today.
I have to say also, just as a layperson, I never knew that fact, even though I'm deep in my own healthcare and deep in trying to be in wellness, until Dr. Jayne shared that with me. It's like, what? That does not seem right, that it's the number one killer of women as well.
As a cardiologist, we have the information, but we are trying to work to not have it so siloed. Meaning, when I say siloed, not just within the cardiology specialty, but the layperson needs to have the information such that they can be armed with it as well.
Yes, absolutely. So I would love to start kind of early on. So we talk a little bit about some of the risk factors for heart disease, and I would love to focus specifically maybe on cholesterol and blood pressure control.
Yeah.
Because I think you and I have spoken offline that the way we're looking at cholesterol is changing. Linsly and I were talking about that. A lot of people in our community do what we're going to call as some outside or more commercial blood work to follow different biomarkers and things like that. And they're starting to get tests back with different names, more than just our HDL and our LDL. Mm-hmm. And not only do consumers not know what to do with that information, a lot of physicians don't know what to do with that information. Mm-hmm. So will you explain a little bit about how cholesterol changes, especially as a woman, as we start to go through menopause, and what we need to be doing, maybe even a little more proactively?
Yeah, let's talk about it. There were a lot of questions in there, so I'm going to pick out the top three. So what are the risk factors for heart disease? We'll start with that. And so the risk factors: high blood pressure, high cholesterol, which we'll talk about in a minute, diabetes, being overweight, being physically inactive, smoking cigarettes. But here are some things that you may not know about. Just your age, advancing age, is a risk factor for heart disease. Perimenopause and menopause, risk factors for heart disease. Pregnancy complications like hypertension in pregnancy, gestational diabetes, preeclampsia, eclampsia, if you've ever heard any of those terms, you've got an increased risk for heart disease. So these are all risk factors for heart disease. And probably the last three people are less familiar with, including in the medical establishment. I've spent the last 2 or 3 years really trying to connect obstetrics and cardiology, because we need to work together in these women with these pregnancy complications, because there needs to be a warm handoff, because these women, after your children, your babies are born safely, really need to be handed off to a cardiologist for long-term care and prevention, because your risk of heart disease has now doubled. In fact, if you have that pregnancy complication, we consider that from a cardiology lens to be a failed stress test. And that's why it's important to have collaboration of specialists. An obstetrician would look at a 32-year-old pregnant female with complications and say, we have a 32-year-old female with preeclampsia. A cardiologist would look at that same patient and describe it as a 32-year-old female with volume overload and a failed stress test. So you see how the lenses are different, and it drives you towards different algorithms of how you're going to get care. And that's incredibly important. So I'm off track there. I'm going to get back to cholesterol, but I wanted to talk about that for a second. Maybe I'll come back for another podcast. All right.
I'll have you back. But yeah, and I think an important part of that is the health disparity in that care even, right? And
yes.
that, there are certain parts of the population that are more affected by that tend to have heart disease, as you pointed out earlier, at a more severe level.
That's right. That's right. And, this has been a message that even has been difficult to get into the medical establishment. We finally have some of the larger medical institutions developing these cardio OB units, where the cardiologist and the obstetrician are embedded there together and taking care of the patient collaboratively, as opposed to it used to be in a silo. You're pregnant, the obstetrician or even high-risk OB takes care of the patient until after the baby is born. And then at some point during one of the postpartum visits, if she's lucky, she might get a referral to a cardiologist. Most do not, because there's not that recognition of, oh my gosh, my patient now has an increased risk of heart disease. The reason for that, in our defense of the medical establishment, I'm going to defend us a little bit, not a lot, but a little bit. What we are taught in medical school and training is that the treatment, this is actually what we are taught, the treatment for preeclampsia, eclampsia, gestational diabetes, hypertension of pregnancy, the treatment is to deliver the baby safely. Once you can deliver the baby and the pregnancy ends, then all of those complications then begin to recede. What we didn't know is that even though those complications recede, their sequela remain. And even though blood pressure may return to normal, diabetes may return to normal, we now know that the sequela, the downstream effect will be this lady will have an increased risk of heart disease. And so in our defense, we were taught part one, but not taught part two. So we always focus on getting that baby delivered so we can get that mother back to being healthy, and not realize that just because all of your indices return to normal, we now have somebody at higher risk. So that's a little bit in our defense, maybe a lot in our defense. And so it's hard to unlearn things. And so now the newer doctors coming out, I'm hoping, we still don't have it really in medical schools. We're trying to teach them this, because it's hard to unlearn and then relearn. It's better to just learn it the right way the first time. That being said, one last thing, science is always changing. Science is always moving. Science is always evolving. So let's not be a doctor and be a part of the medical establishment if we're not able to continue to take in new information.
Or just be a patient who wants to be informed, because science is going to change when you stop being informed. I love your idea of partnerships and those silos, especially thinking about the midlife woman, perimenopause, postmenopause. having that partnership with your gynecologist to say, hey, I'm kicking into this whole new gear. And
Mhm.
menopause has been having a lot of conversation, but I have never heard the conversation about menopause framed as an increased risk factor for heart disease.
Oh, yeah.
So if you can, share a little bit about that. I think Jen started to talk about some of the leading indicators with cholesterol and other markers that consumers might be seeing with these outside blood tests. How could we help frame the mindset for the peri and postmenopause woman to say, hey, this is what I need to be looking for in these results, and how do I talk to my doctor about them?
Yeah, let's talk about that. So, um, here's where I'm going to start. When you're going through perimenopause, or when you start it, and it can start as early as 35, you may not have any early symptoms. So, perimenopause is just the period of time where your estrogen levels start to decrease. You may actually have no symptoms at all early on. And here's the interesting thing, perimenopause can be from 35 to 45 years of age. And you can actually be in perimenopause with estrogen levels decreasing, but also still be fertile and at risk of being pregnant. So that's the,
Got it all
the
going on.
fun 10 years, the fun 10 years when you could be having menopausal symptoms and also be at risk of getting pregnant. Do I take birth control? Do I take hormone replacement? I don't know what's going on. So those are the fun years, right? Those fun 10 years. But as far as medically, as those estrogen levels are dropping, your risk of heart disease is increasing. Why is that? Because estrogen is a cardioprotective agent, meaning it protects the heart. How is that? There are estrogen receptors on the heart, so there's a direct effect of estrogen on the heart, but also estrogen is an anti-inflammatory agent. Chronic inflammation, inflammatory processes in the body drive heart disease. They also drive cancer. It also drives rheumatologic diseases and arthritis. But for the purpose of our context here, let's continue just to talk about heart disease. And so it has this anti-inflammatory effect. So as your estrogen levels are dropping, you are losing what? Fewer receptors are being bound on the heart, so you don't have that direct protection of estrogen, and you're losing that inflammatory effect as well. So you've got more chronic inflammation in your body. Now, how might you feel that? Well, you might start to develop sort of fat around your midsection. That's a result of those estrogen levels decreasing. We call that visceral fat. And what's interesting about this type of fat, it's hard to get rid of. It's easy to get, right? We can just get it by doing nothing. It's hard to get rid of, and it's metabolically active. And so in being active, it does also increase your risk of heart disease. So what else happens during this fun period of time? And we're only going to talk about heart disease. So you can, because of estrogen levels dropping and estrogen receptors also being on your arteries. And this is why I give these talks all of the time, because estrogen and women's health is not just about your breast, your pelvis, your vagina. This is where estrogen is, your ovaries. We have estrogen receptors literally on every organ of our body. Let's stop talking about just reproduction when we talk about our health. That's not what's happening, right? That's almost like a sideshow. It's a distraction. It's distracting us from the real issues.
Wow.
So while we're distracted over here, let me talk about what's really happening. And so as your estrogen levels decrease in your arteries, those arteries become stiffer. Now, the way we maintain normal blood pressure is your arteries are kind of nice and compliant, right? They can kind of expand and contract and expand. And then as they stiffen, they lose that ability for what we call capacity to expand. And so they stay rigid like a pipe, and that keeps your blood pressure up. That's what high blood pressure is in general. And so as we lose that estrogen, you can start to see your blood pressure increasing. People who've never had high blood pressure may suddenly start to have blood pressure during those years, 35 to 60. People who have already high blood pressure, unfortunately, will more than likely see that blood pressure worsen as well. And they are even at further risk. What else happens? As your estrogen levels decrease, you can get your cholesterol levels to rise, which is what Jennifer is asking me about, right? So those cholesterol levels rise. Why is that? Estrogen receptors are in the liver as well. Remember, I told you they're everywhere.
Yes.
And estrogen and cholesterol share a common metabolic pathway where? In the liver. So as your estrogen levels decrease, we get cholesterol levels rising. So I've got blood pressure increasing. That's a risk factor for heart disease. I've got cholesterol increasing. That's a risk factor for heart disease. And then the symptoms of both your estrogen and progesterone levels dropping, what? Sleeplessness, poor sleep, and sleep, duration of sleep, and lack of regularity of sleep are both risk factors for heart disease. And so what happens during this period of time as estrogen and progesterone levels are decreasing? Your quality of sleep may decrease. And in a number of ways, sometimes you can fall asleep easily, but you have multiple awakenings during the night. Or you can go to sleep and then wake up in the middle of the night and not be able to return to sleep. Or maybe you have trouble falling asleep, and right at 5 a.m. when your alarm is going to go off in an hour, you finally drop off to sleep, but then you got to get up in an hour and a half. And so you're chronically fatigued. And so any number of types of insomnia, which we get with these dropping hormonal levels, also increase your risk of heart disease. And then we put on weight, right? Metabolism is decreasing because of the drop of the hormone levels. The fat is accumulating around your middle, which makes it more viscerally active. And so what happens? Now we've got obesity. You don't necessarily have to be obese, but I'm just using obesity just to make the point. Weight gain, maybe. So we've got obesity, we have cholesterol, we have high blood pressure, we've got sleeplessness, all are risk factors for heart disease. So it's amazing that we haven't put 2 and 2 together before now, right? So here we are.
Down right now. Dr. Morgan, okay, I can take this. Let's go.
So
Right.
to go back, most of us don't, like, on average, maybe we see our doctors once a year through this time frame, maybe not even that much. And
Right.
so how often do you think women should be monitoring their blood pressure or monitoring their cholesterol through this time period where we know there's kind of some rapid changes in things?
All the time. And that is why I have joined this company. And let me just tell you something about the company. I'm not plugging the company. I want to tell you a little bit about myself through this company.
Yeah.
Only 3% of health tech companies in the entire world are founded and run by women. And my company, Hello Heart, is one of those 3%. And that was the number one attraction to me. Woman founded and woman owned and a woman CEO, only 3%. And we are focused on women's health because that literally is who we are. We really understand it from that perspective. So my company has a remote blood pressure monitor. Why is that important? It's important because during this time of perimenopause and menopause, you need to monitor your blood pressure all the time. Now, when I say all the time, you don't need to walk around with it everywhere you go for 100% of the time, but every day you need to check your blood pressure, or at least have a day of the week that you're going to check your blood pressure, because you don't want to wait, just as you said, for that annual visit and find out your blood pressure is high and you have no idea how long it's been high.
Yeah.
So you need to get this information so that you can provide it to your physician. This is a blood pressure monitor, it's Bluetooth, connects to an app. There's coaching, gives you lots of information, including asking you how old you are. Might you be in menopause? What are your symptoms? Here's some questions you need to ask your doctor. Here's some information you need to have. Here's what your blood pressure means. It looks as if your blood pressure is high. I want you to take a few breaths, have a seat, separate your feet, put them flat on the floor. Let's try to do it again. And then on top of that, you can have reports that go directly to your doctor if you choose, or you can keep them for yourself and look at the trend lines. And so that's one of the reasons I'm working at this company, because it's incredibly important. On top of that, monitoring cholesterol as well, which is also captured in our app and in our data, and weight. And then the final thing I will say is that data is showing that if you take care of your blood pressure and really seriously monitor it and keep it under control, there's a downstream effect of a lowering of your cholesterol and a decrease of your weight. Why is that? That's because women are so overwhelmed with all the things we have to do and all of our competing priorities that if we can just focus on one thing and do that one thing well, all
Yeah.
of those behavioral and lifestyle changes that go along with managing your blood pressure also positively impact your weight and your cholesterol. So I'm going to come down off my soapbox. I wanted you guys just to know that's why I'm at this company, because it does really what I believe in and what my mission is. So it's furthering my opportunity to have a voice and talk about how important heart disease is for women.
Well, but Dr. Morgan, as you're describing that, I'm thinking of a lot of our audience who's wearing like an Aura ring or a Whoop, or they're trying all these behaviors like breath work. But what I'm hearing as you're describing this is I'm not checking my blood pressure. I don't know how, right? So maybe I'm thinking everything's fine, and it's actually not, because the blood pressure is not directly related to heart rate or other consumer metrics that people are getting. Is that true?
That's right. And blood pressure is integrally associated with heart disease. And it doesn't mean that any of these other devices are not helpful to track different things, but blood pressure is really a critical key. And here's one thing that I will say about the Oura rings and the Fit watches and the Apple watches. If you're someone like me who has a lot of melanin in their skin, these devices work by green light therapy, by emitting light through the skin. So the darker your skin, the less accurate are these devices. So if you were to have cardiac irregularities, a lot of them measure your cardiac irregularity and alert you. You may or may not get alerted, or you may get alerted every other time. Or, so I always say that to understand the risk. Depending on how much melanin you have in your skin, you may or may not be getting accurate readings when you need to know abnormalities. I don't necessarily care about if nothing's going on and you're just, monitoring how many steps you took that day and blah, blah, blah. But if you really need it for cardiac, I'm a cardiologist. We really want to know if you're having any arrhythmia, then I have a lot of concern about it. So what I say to people and to patients, if they're insisting on wearing, and they're wearing it for a medical reason, their doctor has said, I want you to wear this and let me know if you have, irregular heart rate. I ask them to turn the devices, the Oura ring, to the inside of their hand or to the inside of their wrist where there's less melanin. So you must turn it backwards so that the light is emitting through the area, the palm of your hand where there's less color. Yeah. And also the inside of your wrist where generally thin is the skinner and there's less color. So the darker your skin, that's one of the kind of workarounds that I talk with people. But that's a big criticism that I have of that technology, is that they didn't test it on different skin tones, different races. And now, again, how do you put the horse back in the barn? How do you unlearn something that's been learned? So everybody's running around with them, and I'm not 100% convinced that they are safe for people of color. If you actually have a medical problem, you're wearing it to help you with that medical problem. So there's that.
Yeah. But then what I was also hearing, though, is it doesn't actually give you the metric that's the most critical to track, blood pressure.
Right.
And
blood pressure.
Trying to triangulate around it, like, hey, my HRV is looking great, my heart rate is looking great. There's still a question mark, but what about your blood pressure? So I appreciate raising that one.
Yeah. So let's switch gears and focus a little bit on cholesterol, what happens through perimenopause into menopause with that. And if there are additional tests that women should be getting, like maybe a coronary calcium scan and what that can do for you, and some of these other indices that might help us understand disease at an earlier time.
Yeah. So, because you've asked this question before and I still never answered it, I'm going to just focus on cholesterol so we don't run out of time. And I never talked about cholesterol. And then I'll go to the calcium score. So cholesterol, generally people think about it, good cholesterol, bad cholesterol. The good one is the one we call the HDL. So if you get a higher level of that, it tends to protect your heart. I'm talking at a very high level. There are exceptions, right? So there's the good one. And then the bad one is the LDL. I hate categorizing things as good or bad, but this is how people know it. So, and the LDL generally, if that one is high, that one's bad for you. The HDL, if that one's high, that one's good for you. So, LDL stands for low density lipoprotein. And HDL stands for high density lipoprotein. So the high one we want to be high, and the low one we really want to be low. That's the LDL. So if the low one is high, it's bad. If the high one is low, so just so you understand what the nomenclature, it'll help you. HDL is high density lipoprotein. You want it to be high. LDL is low density lipoprotein. You want it to be low. So if you see them going in the opposite directions, they're bad. All right. So there you go. There's a little cholesterol 101 for you. So, but we have a type of cholesterol that's actually worse than the LDL, which is the bad one. It's called LP little a. LP parenthesis, lowercase a parenthesis. Now, do the doctors know about it? Yes, we all know about it. Do we do anything about it? Pretty much we don't. And the reason for it, do we test for it? Probably not. And here's the reason for that. There is no treatment for it. And so as physicians, again, I'm just going to talk about my community. This is actually how we practice. We don't really like testing for stuff that we can't do anything about. So we just don't test for it because the result comes back and then we don't really have anything to offer you. It's kind of, now you know it, and now what? Are you worried or you're not worried? And I can't really offer you anything. So we're trying to change that thinking, because what we have learned is, even though we don't have a therapy for it, meaning an intervention, I can't give you a pill or I can't send you for a procedure that's going to fix it. We know that intensive lifestyle modification can still help you. So in other words, getting that LDL down lower than we would even recommend for the standard patient without an elevated LP little a. Making certain that your blood pressure is treated to goal, meaning 120/80 or less, and it needs to always stay there. So that remote blood pressure monitor might be good for you. Making certain that you're sedentary, you must get up and move, and you have to move every day and really be strict about it. Cigarette smoking, stop it yesterday. No tolerance for it if your LP little a is high. So now we know that intensive coaching and intensive lifestyle modification are really indicated for these patients with LP little a, because we can provide some impact by doing that. Now, part 2, there is actually therapy coming. And you're actually talking to the right person, because I'm on the steering committee of one of the companies that's developing a treatment for LP little a. And this is the Novartis company, in all transparency. Now, are there other companies also developing drugs at the same time? Yes, we've got 3 or 4 different compounds coming to market. It looks as if Novartis's compound, which is where I am on the steering committee, might be first to market in about 2025. And then we may see others coming on in 2027 and 2028. So 2025, as today is December 10th, is really just 3 weeks away, guys.
Yes.
So,
Yes.
so it won't be on January 1st. Let me just tell you that. Don't call me on January 1st looking for your LP little a medicine. But sometime during 2025, we are expecting, hopefully, to get this data in front of the FDA and get some approval for it. So what will it do? It looks as if it probably will be an injection, and it will be a direct therapy for LP little a. If you're testing your LP little a and it is high, it is a risk factor for heart disease, higher than a higher LDL. But why do we test for LDL instead of LP little a? Because we've got therapies for the LDL. We can treat you with statins. We can, we've got options. We don't have any options for LP little a, so we don't test it, because now we can't do anything about it. So just know, if your levels are high, 2 things. I want you to have intense behavior modification. Really be vigilant and aggressive about your health, and make sure you are moving every day. And then the second thing is to make certain that you encourage your family members to also get tested, because there's a strong genetic component, and it runs in families, especially African Americans like myself, and also Southeast Asians. If your LP little a is high mean generally more than 30, encourage other family members as well, especially if you have family members that have had heart attacks early or strokes early, or even they didn't have heart attacks or strokes. You don't know why they died. They died in their sleep, or they collapsed, or they had sudden death and nobody ever knew why. If you have people like that in your family history, your cousin, before you were born, they still talk about how he just collapsed one day when he was 22 or 28. Those are the kinds of things in your family history that might be a hint that you may need to check your LP little a. Now, obviously, it could be other things. So that's the little bit of the cholesterol conversation.
And Jayne, there's a lot of kind of, I guess, research, maybe it's not even research based, but a lot of the recommendations are that you only need to check your LP little a once, because there's not much we can do about it. It doesn't really change, even with, like, the number's not going to change with lifestyle modification, but you're lowering your risk by lowering everything else.
Right.
But do we know what happens through menopause when the rest of our cholesterol numbers? Have we done enough research in that area to say, I mean, I have an LP little a of 222. And so it's like, do I need to check mine? I checked mine at 44. Do I need one at 49 to say what's happening? And even if it doesn't matter, just to build that database to say, we're learning more about midlife women. And as these drugs are coming on board, is this modifiable? Does this become a more modifiable risk?
Right. So as always, Jennifer, you asked me a number of questions in there, so I'm going to get to all of. So the drugs that are coming on market, I'm just going to talk about, at a high level. Will also lower your LP little a. So, but what are we actually looking at? We don't necessarily care if it lowers your LP little a. What we are looking at when we're looking and developing this drug is cardiovascular outcomes. So we don't necessarily, it's nice if it lowers it. We don't want to lower it and then your heart disease risk is the same. We'd rather lower the heart disease risk and the LP little a is the same. So, if they both come down, great, because then we can correlate them. But if they don't, we really are looking for cardiovascular outcomes. So that's number one. Number two, we do not know about menopause. And there is a school of thought that I am in that school. I might actually have even started that school. I'm not sure. But there's a school of thought that LP little a needs to be rechecked during menopause at a 10-year mark. A woman should have it checked during menopause, not because we think it's going to change, but because we have no idea what's happening to it, and we need to start getting that information. And it may change. We don't know what the effects of menopause are on LP little a. The other thing that we need to know with regard to that is research. And so, again, at a high level, what I'm going to say about research is research takes a long time to develop. Randomized clinical trials and evidence-based medicine take a long time to develop, 10 years, 20 years. I don't want to wait for another generation of women to go through for us to have randomized clinical trials, evidence-based medicine. Now, shame on the medical establishment for not having this information already. But if we were to even start to gather it today, we may not actually have real robust data for another 1 to 2 decades. So how does that help us here? So now I'm kind of back to what I do with my company. When we're talking about artificial intelligence, it is my hope and drive as I, sit on these different committees, that artificial intelligence will allow us to not only enroll more quickly into trials, but to identify people that need to be in those trials, but then to be able to have fewer people, because the artificial intelligence can fill in those gaps and scale it more quickly and get us information. So it may be, again, this is my school of thought. This might be the school of thought of Jayne, the only one there, that evidence-based medicine may be rapidly going into our rearview mirror as we continue to have artificial intelligence march forward, and we can actually produce robust data in a safe way using artificial intelligence more safely and also more rapidly, especially for the female population. And, evidence-based medicine may not be the way to go. So you heard it here first. That's heresy. If you were to say that in the medical establishment, we always treat patients based on evidence-based medicine. And here I'm saying, that may not be the way to go for women. We've already waited a century. We don't really want to wait 20 more years. So why don't we utilize artificial intelligence to move this along? Let's get the data and get the information.
If I could also kind of come back and ask a little bit of the layperson question, because I think there's been a lot of awareness about the cholesterol markers, and HDL and LDL are something that I am postmenopause. I'm 55, and so I've grown up tracking that. I have what people might say is genetic high cholesterol, and so I track that. I've got low blood pressure, low heart rate historically, but now the marker that I hear a lot about is ApoB. And so that gets a lot of play in the media. And so people who are trying to understand what else they should ask their doctor about, I've heard LP little a. I've heard a great filtering of how to understand LDL and HDL. How does ApoB relate to those metrics if that's something that's coming up in these consumer platform tests?
Yeah. And so, I kind of am a fan of these platform tests and not a fan, but it's nice to get the information. It's not so nice if you don't really know what to do with it.
Yes.
But take it to your doctor. Yeah. ApoA and ApoB are both components of LP little a.
Okay.
So this is a component of the LP little a. And so ultimately what is going to happen in drive therapy is if you have LP little a, looking to see perhaps which component is more dominant. Now, generally there is one component that's more dominant, but it is a part of LP little a.
Okay. And so then when we talk with midlife women, we very much emphasize what you've surfaced. Okay. Movement, you got to move. Nutrition and having the right kind of profile.
Nutrition. Right. We didn't talk about nutrition. We can't talk about everything today, guys.
Right. That's right. And sleep.
Right.
We talk about that too. Is there anything else when you're, the overarching message is information based, like, hey, you're a woman, especially if you're a midlife woman, we need you to have this information. Perimenopause, postmenopause, change the equation for you. If you had any complications with your pregnancies, they're lingering. So have that in the conversation with your doctor. Right. Is there anything else that we should put on offer to midlife women so they kind of take this health red alarm bell into their own hands and can start to feel a sense of not total control, but at least a sense of ownership for their health and how to manage this risk?
Linsly, there is. So again, as a cardiologist, one of the things that concerns me is that the symptoms of a heart attack of a woman are generally not well recognized by women, by men, by EMS services, by the hospital. Nobody's really recognizing them, right? And generally, we look at the symptoms of a heart attack, just like you see on TV. You have chest pain, you get shortness of breath, you start to sweat, you might collapse, somebody starts CPR, but and a woman can have those, but she actually may not. And the reason for that is that oftentimes women don't have one big blockage of their heart that causes these dramatic symptoms. Women have something that we call studded atherosclerosis. So you might have little small patches that are dotting the entire artery as it goes along, as opposed to one big blockage. So it's not so much that it's blocked, but the passage of blood has to kind of meander through because you have just small little blockages on either side. Because of that, it's also harder to treat, but your symptoms may be more subtle. So here's a symptom of maybe a woman who's having a heart attack. Wow, I feel tired today. Anybody run into the ER?
No.
Oh, wow, I think my jaw is hurting. Should I call my dentist? I feel like I've had the flu for 2 weeks. I just can't seem to shake it. Why do I feel like I have the flu? I'm so run down. My back is hurting. I cannot, I've taken Tylenol. I sit down. I think it feels better when I sit down, but I'm not sure. I have all this back pain. Oh, my right arm just keeps hurting me. I think I'm, lifting too many weights on the right side. Mm-hmm. So, we think about left arm pain. A woman may have right arm pain. We think about chest pain. The woman's chest pain may actually radiate to the jaw, which may send her to the dentist. Because you've got that studded plaques in your arteries, is decreasing your blood flow, but it's not actually blocked. So your oxygen levels are decreased. You just feel tired. Think about it. women at midlife, we've got parents we might be taking care of. You've got kids that are still running around doing all kinds of things. You're working full time. Who's not tired?
Right.
Who doesn't have back pain?
Yeah, right.
And and because we're not trained to think of these symptoms in a way that is responsive to women, we're more often misunderstood, misdiagnosed. Here's something else that I'm always on my soapbox about. Even in medical school, we are taught that those symptoms that I just described for you are atypical. That's actually the language that we use. It is the language that would be dictated into a chart. 54-year-old female with atypical symptoms has just presented to the emergency room. Atypical chest pain. Just that word atypical drives behavior. It basically is insinuating, it's probably not. And that's why I don't like that word. The other reason I don't like that word is that women are the majority of the population. Mm-hmm. I don't know how our symptoms got to be atypical. Maybe it's the man's symptoms that are atypical. We're actually the majority of the population. So that just goes to show you the patriarchy that runs medicine has deemed our symptoms as atypical, and it drives the entire behavior of the medical establishment and also the public. Right. So it's one reason why the first heart attack of a woman is more often fatal than the first heart attack of a man. Couple of reasons for that. We're slow to recognize what it is. We, meaning women, by the time we go to the hospital establishment is slow to recognize what it is. And what does that mean? It means you have delay in your care. Delay is never good when you're having a heart attack. Delay never helps when you're having a heart attack. Also, women are less likely to be referred to the cardiac cath lab because of that delay. That's where those major interventions are happening, those stents, and where your arteries are being opened, where all the men are getting, treatment for those big clots that they have, those big blockages, but we have these small studded ones. And so therefore, we are more likely to die from a first heart attack. Something else that's also more common in women, a woman is more likely to present to the hospital with evidence on her EKG that she's had a heart attack in the past, right? And didn't realize it. So these are all things that can happen. So that's one thing, that I want to leave with your listeners and your viewers, that the symptoms of a heart attack of a woman may be different than those of a man. And, I'm not blaming you. These are vague symptoms. You're tired. You're run down. You've got back pain. I get it. I get it. Why you didn't run off to the emergency room. But I now want you to think about, am I 50? Am I tired? Start putting them together and say, you know what? I'm just going to go to the ER and get checked out. And when you get to the ER, if they're dismissing you, here's a trick, a tool I'm going to give to you to get people to pay attention to you if you are unable to advocate for yourself. And it's hard to advocate in a big medical system where everybody's got all the knowledge and they're like, there's nothing wrong with you. We're discharging you. Everybody's dismissing you. Say, excuse me, doctor, or excuse me, nurse, could you just get an EKG on me before I go? Mm-hmm. That will stop people in their tracks because you can't say no. You got to get it. And that's all you want. So I wouldn't argue with them and say, but I heard this podcast that I could be having a heart attack. Just don't even do that. Just say, hey, would you mind getting an EKG before I go? And that's the end of that conversation. Okay. They can get the EKG, and that drives the thought in there. So there's just a little tool of how you navigate the system. Yes. Right.
As we finish up and close out, I just want to kind of review because we covered so much today.
I know,
which is awesome. And we're definitely going to have you back to cover more because there's so much more here. But to review, heart disease is still the number one killer of women. And so we need to prioritize this in our lives.
That's right.
We need to be checking our blood pressure way more often than probably most of us.
Yes.
So,
which means you need to get something remotely. I'm not saying go to the fire station or get, have something at your house. Now, obviously, I have Hello Heart. That's what we do. But have something.
Have something.
So that you can do it. Because if you don't have it, you won't do it.
Exactly.
That's
right.
We need to check our cholesterol and our LP little A1s. And then we need to check it 10 years into menopause. Maybe not to help us, but to help the next generation and build that database.
And maybe to help you as well. And there's no science behind that. I want to be clear. That's according to Dr. Jayne. I just said that. And that's what I think, right?
And then we need to understand what the symptoms of a heart attack are in women, and that they're very different. And you know your body, and you know you're just not feeling right.
Right.
To advocate for yourself. And minimum, when you get to the emergency room, if you're really worried, ask for an EKG.
There you go.
Now, I have one other question. Do you think women in menopause should have a baseline EKG with their
Always?
Okay.
Yes. Right.
Yeah.
You need to have a baseline EKG. And here's something else. Most men, when they go for the physical exams, get an EKG. They have one. Women do not. So when you're going, it's such a great point, Jennifer, when you're going for your physical exam, if you do not get an EKG at your physical exam, if you've never had one, ask for one. And if they ask you why, are you feeling sick? Say no, but I would like to have one on my record as just a baseline. This is just your annual physical exam. Again, why is that? Because we're focused on all the reproductive systems. We're trying to do a GYN exam. We're doing a breast exam. We're sending you for the mammogram. We forget that the women have a heart. We're just like, oh, we got to do all these things.
Yeah.
Ask for an EKG. And the reason you want it is you just want a baseline on your record.
Yeah. You know, I think the other thing that you really highlighted for us, Dr. Jayne, is the stuff we talk about, like movement, nutrition, sleep. It may not be that you're noticing immediate impact on the obvious markers, like your weight or like your energy, or sometimes we hear pushback from women, like, I'm doing the stuff and I'm not seeing the results. But what you've made perfectly clear is you do these things for your heart health.
That's
never
right.
mind what the scale says. Never mind if you got perfect sleep and your Oura ring set. So you keep to these baseline principles, because that's the number one preventative thing you can do for your heart, and that's the number one killer of women.
Such a good point. Unfortunately, you may not see the benefit in your physical appearance, but what I'm talking about is how it looks inside, the things you can't see that I might look at later, your heart.
Yes.
So there will be a benefit to that heart. And heart is made of striated muscles. It's the same type of muscle that we have in our legs and in our arms, the same kind of muscle. So working that heart improves that strength. And so I say, as we get older, you need to move and work out to be strong and to be healthy and to have prevention, and not necessarily for vanity. It's nice. There will be some benefits. Those who work out and move generally weigh less. It is true. So there are some benefits, but don't be discouraged if you are not achieving the goal that you set for yourself, because your internal organ goal is what I'm talking about. And those are the goals that we want to set.
Yes. It's fantastic.
Well, thank you, Dr. Jayne. This has been enlightening. This has been wonderful. We are so appreciative of you taking the time to talk with us and share all of your knowledge. We'll definitely try to get you back after the holidays, when life maybe calms down or maybe doesn't.
With all kinds of product launches, maybe not.
Awesome. So thank you for your time. We really appreciate it. We will definitely link Hello Heart in our show notes so people can find it and follow what you're doing and all of this great stuff to expand the platform of women's health. So thank you.
Oh, I appreciate it. And have me back. There's always so much to talk about. We can't get it done in an hour, but it's a good place to start.
Yes.
And listen, let me also say, please follow me on social media. You can follow me on Instagram at Dr. Jayne Morgan, DrJayne on Instagram. You can also find me on LinkedIn, Jayne Morgan, MD, but all of the platforms, Dr. Jayne Morgan. I generally only talk about science and medicine all the time, and I'm a big proponent of women's health. So
yes,
wonderful.
Follow along.
Thank you so much.
Bye.
Thank you so much for spending your time with us here today. If you liked what you heard and you got some tips on how to live better right now and for the long haul, please help us reach more midlife women. Please share and rate and like this show. And we can't wait to continue the dialogue with you on our next episode. Until then, thank you. It's time.